strike that. The last Zoom meeting of the Children's Commission. So that's where everybody applauses, and we're very thankful to see you next time in person, in the flesh. But in the meantime, we will carry forth on this medium and adopt, I believe, the minutes from the April meeting. So do I have a motion to adopt those minutes?
So moved.
Second.
All in favor of adopting the minutes from the April meeting?
Aye.
Aye.
All opposed? The agenda has been consented on. Moving forward, you're right, Julie, we do have all our guests on. And first up, we've got really important topic on uninsured children. We've got joining us Mark Fairchild, who's our subcommittee chair, covering kids and families, who's put together really good presentation, which is going to be followed by pretty important action item and recommendation on the CHIP waiting period. So I'm going to turn it over to Mark Fairchild.
All right, thank you, and thanks for having me today for this last virtual meeting. I too can't wait to do this in person. It's just a totally different animal. We can do it that way. But yeah, so this is one of our newer initiatives. The Commission decided to dive into children's health coverage under the Health and Safety Task Force going on about 2 years ago. So this will be our first recommendation from this group. But first I want to start with just a little bit of a topic overview, because this is a new area for the Commission to be going into in detail. So again, this is a subcommittee of the group doing child health and safety. I think I'll go to the next slide, Julie. Okay, so just a bit of an overview. This is some of the issue of why we decided we really needed to target this more specifically than perhaps we had in the past. So tracking some of the trends, traditionally, the rate for children being uninsured has been positive for quite some time. As you can see from the slide, dropping to 4.7% in 2016, but it started slowly creeping up. And the national rate going up to 5.7% in 2019. And unfortunately, Indiana is on the bad end of that trend. So we've moved all the way up to 7.1% uninsured in 2019, representing about 20,000 more uninsured children just through that recent time period. So definitely a disturbing trend, especially when we count all the things that happened during that time period for kids when they're uninsured. And just a note at the bottom there, and as we go through too, we're presenting a lot of pre-COVID data. The COVID data is very, very unique set, a lot of moving pieces on that, yet FSSA is scrambling with about 30 different teams trying to figure out what to do with that and what to pull from that. So we'll keep that in context as we go, and that's we're also making sure our recommendations apply to things that really are less heavily touched by COVID-related variables. Okay. Next slide. All right, so again, just some basics, but things we certainly see when we have uninsured kids, the reduced access to medical care. I do like to talk about health coverage when we look at having our kids insured. That's really, that's the first part of access. So I really want to look at coverage as an access issue. If you don't have coverage, you're really left with emergent level care, which of course then you're not getting all your good preventative stuff, your developmental screenings, which we have another group working on that as well under the Commission, childhood vaccinations, everything that should be looked at, and all those checks and balances just by having a set of eyes on the child. All those opportunities for the parents to learn, right? When you're connected to a good primary care doc, that's as much about educating the parents as it is about what you're doing directly with the kids, sometimes more so, right? So if we don't have that relationship, the parents are losing a lot of great opportunities to get quality education. And we can make some sub-commentary about the educational resources available online and such that some folks feel forced to turn to, and we know a physician is always the better place for that information. And of course, all those opportunities for the child to learn healthy habits, all those good things we want them to see into adulthood, especially as we're looking at all of our health disparity factors and everything else going on in the state and nationwide. That's a great place for them to get that extra piece of health education early on in their life. Okay. Next slide. Great. And of course, on the other end, we know Medicaid coverage specifically, we've done a lot of studies that when we have them linked to Medicaid, most of this does apply to other insurance products, of course, but decreased reports of mental health problems, a lot of study going on in that realm now, especially with COVID, because in some ways we've managed to increase access with virtual care. Some of the pieces that have come in place there, decreased likelihood of eating disorders, high risk sexual behavior, smoking and alcohol use, obesity, late onset diabetes, blood pressure, heart disease, all those things that flow into adulthood as we go on. So again, shouldn't be a lot of surprises here, but we know these are all things that we talk about tackling at the adult level all the time, and we really need to make sure that we're looking at how that plays into behaviors that they learned early on in life, right? Next slide. And of course, yeah, like Dr. Sullivan, Medicaid equals good, yeah. Related agencies, realistically, this is most of our state agencies, but as we talk too about how we can interconnect getting kids covered and making sure that they covered, this plays in both directions, certainly falls under our Nowhere on Door approach as well. So obviously FSSA is the lead with the Office of Medicaid Policy and Planning underneath them there, but Department of Health, Department of Education, Child Services, Correction, of course, the Department of Insurance, all these are playing a role as far as being a door to get them linked up properly with coverage, but also all these agencies have a vested interest, right, in making sure that the kids do have coverage. There's a lot of things that can happen. I worked in education for a time, certainly know what happened when we hit the roadblock of maybe having to wait 6 months to get some kind of waiver in place or coverage lined up so we could really connect the right services. Always hated that situation. Child services, populations and such too, getting things lined up properly right from the start, keeping things seamless. Department of Corrections doing a lot of work there about making sure we have seamless coverage available for kids, for adolescents, and for adults, right? So this all flows through that same pipeline as we're looking forward to what touches healthcare coverage. And really, I could make a list of probably all of the state agencies if we went into that. But these are also all places where people might approach to figure out their health coverage needs, and do certainly approach to figure out their health coverage needs. I think my organization, Covering Kids and Families, has outstationing and different arrangements through all of these entities because we know that's where that happens. Okay, next slide. Okay, so here's the big list, and these are not recommendations we're making today. I want to be clear because there's like a lot of big stuff on here. But all the stuff that we've explored through the subcommittee and looked at. And the good thing is there's a lot of the stuff that's been accomplished or is currently being looked at in relation to COVID and everything else. But the big one on the top, extension of postpartum Medicaid coverage, huge, right? And we did get that one. So it's always nice when those things happen, things lined up perfectly for it, we're able to get that in place. Dr. Sullivan and her team acted very quickly to get that lined up, and we couldn't be more thrilled because that's really a great case of lives saved. I mean, that it really is that dramatic of an impact.
Hey, Mark, we remind the commission, is that 12 months now of postpartum Medicaid coverage? Right.
So yes, that'll be extended out for that full first year. So that is dramatic. So we had very limited coverage before that. I used to say that, you know, in those first couple of months that were covered before, that might be enough time to get one appointment together, right? Yeah, and to clarify, it does start in April of 22 when we get to that. Right now, we're still under the COVID moratoriums that say, well, but nobody's getting removed from coverage now anyway. So we're effectively in that zone. Right, so full effect next year, but we're in that zone now. Very cool to see that. Other things we looked at, extending continuous eligibility. We looked at this specifically in the Children's Health Insurance Program. And this is just the idea of not having to do quite as many income checks and things along the way while a child's at a certain age, right? Some states are looking at saying, do we need to make that so for the first 5 years of life? We make it easier for them to stay on the program. That yes, you still do your redeterminations annually, and you make sure that you've got those checks in place, but that we're not looking at a regular, like monthly interval of checking in on some things. So more about keeping continuous coverage and less about checking for variables on an ongoing basis. So that's when we've poked into. All these are ones you might hear more from me about in the future if we get to the point of making some clear recommendations. Looking at promotion of program enrollment assistance, and this specifically be things like navigator programs, other outside entities that are there that are maybe stationed at schools, at health departments and elsewhere. Is there a way that we can promote that that's available, right? And those programs are great because they employ experts that simply say, if you're having difficulty enrolling, if you don't know what kind of paper I need or how to line that all up or what programs. And sometimes it's really just a matter of, as easy as the online portal that FSSA has together for getting enrolled and everything is, sometimes it's just people have that paralysis of system complexity and worry, sometimes some stigma about enrolling in Medicaid and stuff. So if we can have some of those assistance programs a little bit better known to people, they might feel better calling somebody that's in that more neutral advocate role to help get them started on doing an application for coverage. So looking if there's more ways we can get involved with that. I think right now the Navigator portal through the Indiana Department of Insurance is the main way to get linked up to those entities. But we did have a fun experience of the consumer journey of getting to that. And that involved the consumer knowing about things like the Indiana Department of Insurance and how it works, what this word navigator even means, right? So we did talk about, well, maybe the pathway can be smoothed out a little bit and we can use more consumer-friendly words well before they even get to that site, describing these kind of services and how they work. And that really went into that next point on the list is retooling communication and outreach strategies. And again, this isn't even necessarily looking at the agency level or internal to FSSA and OMPP, but how do we talk about health coverage, right? With my company, I'll use the example, we love to say that we help, we have navigators that help enroll people in health coverage programs. Very few of those words are words that a consumer is ever going to use, right? So how do we get better about that? I'll talk with entities a little bit about saying, you know what, they're going to use the word insurance. It's okay for us to use the word insurance because that's what the consumer is looking for, right? We meet them where they're at, and then we can refine the language as we evolve and go into there. So that's probably going to be one of the next big things we go into, especially since there was so much more outreach and specialized outreach during COVID about getting people signed in. Or signed up, look back, see what works, see what kind of retooling can be done at agency levels, outside of agencies, and with all of the different groups that are trying to just promote healthcare coverage for kids, right? A ton of work to do there, but it is difficult, right? We're talking Medicaid, we're talking health insurance, we're talking through all these different systems. Getting the jargon out of the way is a big important step, and finding the correct replacement words that get people comfortable. And not even comfortable, but when they see the word, they know what we're talking about. It's so important and something that maybe we've missed in the past throughout the healthcare coverage community. Okay, a few more specific ones that we've looked at that definitely require a much bigger looking at adjusting the income thresholds for the children's health insurance program. Right now, the Children's Health Insurance Program goes up to roughly, there's some rounding and disregards in there, roughly 250% of the federal poverty level. There are states that have gone higher than that. So just doing assessment and saying, well, who else do we capture if we go higher? What can happen there? For an odd piece of history, by the way, the Indiana General Assembly once did vote successfully to allow CHIP threshold to go up to 400%. But that was right at the middle of the Great Recession that we had a few years ago. And it was decided that money was probably better invested into things like the Healthy Indiana Plan. So, which I think we can agree, that's been a great success. So there has been an appetite there before. It's tricky, so we're not going to go on that today. But that's something that could be on the table. Looking at the premiums for the Children's Health Insurance Program. Again, these are highly reduced premiums for families. Not something we see a great need to adjust those, but certainly something we're going to look at. We're looking at around $25 or so is, your monthly rates there. It's nothing dramatic, but we also know for some families that any amount of a premium can be a difficulty, right? A very big one that came in late in our discussion, so I'm just going to put this one on the table because this requires like lots and lots of analysis there. So the CHIP program has a 5-year waiting period, technically CHIP and Medicaid, a 5-year waiting period for lawful immigrant children. So just like it sounds, if you're a lawful immigrant in the country legally and documented, there is a 5-year waiting period to get signed up for these programs. These families traditionally go into using emergency Medicaid, and some other systems are in place. I won't say that there isn't a safety net there. There certainly is. But it is a population that gets a gap as far as their ability to access quality, regular care if their income requires that to be through something like CHIP or Medicaid. So there is that wait period there. That's something I know is being federally as we speak. There's some bills that have been introduced. So go put them on the table just as another example of something that is in place. Their last one on the list, which will be our recommendation for today, is elimination of the CHIP 90-day rule. So we will go into that here. So next slide, please. Okay, so moving on to our action request. So we're recommending that OMPP eliminate the 90-day waiting period of the CHIP program. And I have put some guardrails on this, and as we go through, I'll describe them a little bit more. But this will be pending fiscal viability analysis by OMPP. So they're going to look at the numbers and see what the timing looks like, see what makes sense to do there before any implementation. Also, given the current workload of OMPP, they're doing a lot of stuff with state plan amendments and just tracking all kinds of data. Budget-wise, I don't know what kind of miracle workers they have trying to sort through all the different numbers that are coming and going and flowing. So it also recommendation that any implementation timeline be at OMPP's discretion. We're not going to say this has to be done in the next 3 months, 6 months. There's a lot of things in the queue through the office there. So the waiting period itself is basically that children who are voluntarily dropped from private coverage, so their parents maybe have employer-sponsored coverage, for whatever reason they drop that coverage, they have to wait 90 days before they can be eligible for CHIP coverage. So that Children's Health Insurance Program and those low premiums that come with CHIP. We find that a lot of times voluntary drops, really most time voluntary drops are due to unaffordable employer-sponsored insurance. I want to make sure this is clear though too. If an employer were to terminate coverage, or if the person were to get laid off or terminated, this rule doesn't apply to those folks. This is only if it's voluntarily dropped, right? So it's a very specific group. Now, it's important to pause here too and realize this group is a group that probably most of us can relate to. I know at several stages of my career, I've been in a similar position because a lot of employers, they'll pay a large portion of the health insurance cost for the individual employee. But when it gets to family coverage, that's where it can get a lot more expensive, right? Some kick in a small amount, some kick in nothing. And depending on the quality of coverage they have, it can be very, very expensive when you get to that family level coverage, right? I've had it before where they said, well, if you want to cover your family, it's going to be $500 a month. Well, yeah, early in my career, $500 a month was a lot of money that I didn't have a way to come up with, right? Versus looking at CHIP premiums where getting at least the kids covered would be something that would be much, much more affordable than that, right? So it does create a pretty realistic drop as far as what they can get. So in just a little bit of data, so this is a rule that's been in place for a little while, but as of April of 2021, only 14 states have a waiting period. These waiting periods can be up to 90 days. See, one state has a shorter one, 2 states have a 1-month waiting period. Indiana is, of course, on that full 90-day end of the spectrum as far as what's allowed, but it has been the trend for states to drop that waiting period. Most of them have said, well, we're just going to do a little bit further checks to make absolute certainty that the employer coverage is dropped and stays dropped, things like that, to make sure there's no attempted duplicating coverage or anything malicious going on there. And very few of them have found any type of behavior that's been such as that. So next slide, please. Okay, so of course we want to go into a little bit of what some of the disparate impact is that we look at, especially when we're looking at children's health coverage. It's important to note that this is a lot of times going to be coupled with other barriers experienced by our minority and low income populations. So any system complexity, any additional rule are more likely to deter that initial application and any reapplications that are needed, right? I'm a firm believer in that last straw approach to say, this rule seems fairly innocuous and fairly minor compared to some things, but if you've already had to go past maybe language barriers to even understand the application process, if you've had to find the time to go through it because you're working 2 jobs and holding on, if you've tried to deal with a lot of other things throughout systems and stigmas and everything else, and then you go to apply, go into the process, and you hit this kind of wall, it's not hard to imagine putting your arms up in the air in frustration and saying, I'm just done with this, right? And we know that's going to happen much more commonly with those populations that already have a lot of disparities following around them. Also in that group, we know gaps in coverage with children result in those missed opportunities for vaccinations, developmental screenings, early interventions. And it's important to know too, because groups that are already in those disparity bubbles, we know they were already at high risk for some of these gaps in being able to access it appropriately, utilize it well, have it communicated to them appropriately. And now we're saying, if you are in a place where you have to drop that employer-sponsored coverage, you have to go uninsured for 90 days. Insurance is definitely, and using your insurance is a habit, and habits are hard to make and easy to break. And a 90-day gap can easily become a long-term gap as far as going back, reestablishing provider connections, getting those appointments scheduled again, right? So we know maintaining that continuity of access to care, promoting all those healthcare resources is so important for these groups to begin with, and a gap or a system complexity that makes them just walk away and say, look, I'm not going to bother reapplying again, can be a really dangerous thing for these families, because we know we want to connect them really from day one and keep them connected to all the health resources we can from day one, where there's just a lot of risk of them moving away from those systems altogether. Okay, next slide. All right, so I want to give you some numbers of what we're actually looking at here. So these are straight from OMPP as far as some of the application types that they see that fall against this. And of course, you can see 2020 as an asterisk, as it will for all of time, because the waiting day period was suspended as we went into 2020. Right. Some of the numbers here, I'll just go through briefly. So we have, these are folks that applied and were denied. So you see 2 reasons listed there. One is that at the time of application, the child was insured, right? So these are folks that would have been informed and saying, hey, you're still insured, that coverage will need to be dropped, and you'll need to wait 90 days to reapply. Then you see a much smaller group under that of ones that have already dropped the coverage, right? And these would be ones that have dropped it, but are being informed, hey, but you got to wait 90 days, even though you're currently uninsured. You can see a very small group there. So 22, 28, and 12 going across 27, 2018, and 2019. So these are the ones that if we were to eliminate the rule, definitely when they applied would have just been accepted and given coverage, okay? Provided that they met all the other criteria, of course, but they wouldn't have hit that rule. The group above that was a little bit of a harder group, because you can see where that was in some of the thousands there. Those are ones that we say would fit, thanks for going back there. Those are the ones that would fit maybe the deterrent category. So they were investigating CHIP. They said, you know, I'm going to apply. I can't afford what my insurer has. Maybe I can get on CHIP. And they're the ones that maybe they're told, okay, well, you're going to drop and wait 90 days. Now you've got a decision to make. Did they drop? did they drop their employer-sponsored insurance but not end up reapplying to CHIP? The one thing we know for sure is if they dropped their employer-sponsored coverage and did apply for CHIP, they had to wait 90 days and their child was uninsured for that 90-day period. So we know that there's been a gap there for those that chose to reapply. What we don't know is was there a deterrent effect of people that went on struggling paying an expensive employer-sponsored bill, or that just maybe walked away from coverage altogether, which we hope is never the case, but you know, when a family has those kind of frustrations, that certainly does happen. So when we go into math, you can see where it gets a little trickier. We've got a very small guarantee, yes, they would have been in CHIP group, but then we've got another group there where I think we can fairly say, you know, maybe half of them would have made the decision to go ahead and drop the insurance and get enrolled in CHIP if they hadn't faced that 90-day period. But this is why we're having the ability for OMPP to do a real viability analysis before full implementation, so they can do the math on this, get a little bit better feel on the figures and make sure they can do it. I would say that overall CHIP enrollment, when we see these numbers here, overall CHIP enrollment usually is between 100 and 115,000 kiddos. So we're not looking at a massive jump in population size here, right? And we can say, if we want a little bit of clue of the people who might sign on, you can see the difference between 2019 and 2020, where we've got 4,000 in that top number, and then it goes to 1,500 in 2020. So we can say, well, technically speaking, in that case, when we did away with the rule, there maybe was somewhere in the neighborhood of 2,500 people in a traditional year that would have hit that rule. Now, a COVID year is different, and a lot of people lost insurance through their employer, and a lot of kids went a lot of different directions. So we can't make that completely a direct analogy, but it does give you an idea of, in a worst case scenario, when we drop the rule, looks like about 2,500 more people maybe gained access to the program directly that way. So a little bit of a number for you. Okay, next slide, please. Okay, so just want to make sure that we got our code reference in here of where we're saying that the change should occur. So this waiting period is within the Indiana Code and the administrative code. Within Indiana Code, the good thing is we have it under a may provision. So under section 4 there, you can see the office may do the following. And then we discussed determine a waiting period that may not exceed 3 months, and exceptions to the requirement of the waiting period, et cetera. So really the Indiana Code piece, we're under a may provision. So this gives permission for the office to do what they choose to do there. So that's nice. We like the flexibility of may provision here. It does make the recommendation a little bit easier to implement. So, and then within the administrative code, you can see the language we have there. So first part, by the way, except as provided under in subsection B. I don't have subsection B listed here. Those are people that lost coverage through their employer terminating their coverage or terminating their employment. So that's talking about the involuntary drop group when we talk about subsection B. But an individual who is covered under a group health plan or under health insurance coverage is ineligible for CHIP for 3 months from the effective date of termination of that coverage. So this is what's within the administrative code. So this is the part that would need to be changed out. We'd recommend, language you could say shall not be imposed a waiting period, or frankly, you could drop this block as would no longer apply if we're doing away with waiting periods within the CHIP program. So that language can be worked out specifically or removed. I think either way we're in good shape. It's probably a matter if we want to retain a holding block in case there was a need to come back to a waiting period, or if we want to eliminate it altogether in that language. Okay, so that's the block of that. Next slide, please. And then we'll leave some time for questions and everything. So I know I'm running us through pretty quick. But do want to note that this recommendation was crafted with direct involvement from the Office of Medicaid Policy and Planning, Children's Health Insurance Program. So Ben Brown, who's over a lot of the Hoosier HealthWise stuff, has been providing all these wonderful stats and everything, which is great because that's a lot less for us to have to dig for as we go through. Of course, we're requesting for the commission recommendation to eliminate this 90-day rule. And really, like a small cost portfolio as we go through that. We really hope that you can see this as a starting point and looking at a good first step of how we can stuff that is going on with children's health coverage, not just within the agency, but how everybody who's surrounding the issue of children's health coverage can do some good work to get those numbers of coverage back up, get us in a better place, and really hope reversing those trends and get us back to where we see children's health insurance rates going to improve year after year after year, and we can get back to where we want to see that again. So I'll pause here for any questions anybody might have.
Any questions from commission members? Well, Mark, thank you. Before we take the action for an incredibly well-organized presentation, I think most helpful is sort of the forecast of some of the other work that the subcommittee is going to be doing and putting this sort of in the proper context with all that. Obviously, this is a continuation of something that we've been able to do during the pandemic. And I think you described, like you said, it's not exactly an A to B line, but what the potential impact could be. And while small compared to the volume of CHIP recipients, 2,500 families without having to run into this barrier or potential last straw would have an impact, and still giving OMPP the flexibility that they need on the timing of the implementation. So I just want to thank you. This is exactly how recommendations, particularly ones with a lot of complexity, but also obviously impact, should be brought through the commission. And we just want to thank you for helping kind of lay that out in such a thoughtful way, and Julie for staying on top of this and making sure this got also on the agenda. So unless there's anything else to say on that topic, of course, I've got Dr. Sullivan live and in person if she wants to add anything in, and then I can get to the order of business.
Thank you, John. You know, I can't help but chime in with support for Mark, who I just think does a phenomenal job as a partner with us to help identify the sort of the low-hanging fruit that helps us get to our long-term goals. You know, our long-term goals for children to have health coverage in Indiana happen in lots of different ways. You know, I work in the emergency department for a reason. I work every Tuesday, work till midnight last night. And just yesterday, I had a child come in with a breakthrough seizure because they were in their waiting period and couldn't get their seizure medicines as their parents had lost health coverage and they weren't able to get in the next round. So the tangible outputs of making sure that we have continuous coverage for kids is really a huge deal, and one makes a difference. So I appreciate all of these teams coming together to think about all the different ways that we can reverse that trend. We had this, Mark and I talk about this, we've had this incredible trend, and to see that dip in 2019 is not that folks don't want their kids to have health coverage, it's because there's an assumption that if the parent isn't eligible, that the child is not. And so because we have different eligibility limits across our different programs, we really have to do this special push for CHIP to make sure that those kids have access when they need it, where they need it without barriers. So I appreciate your thoughtfulness, and I look forward to potentially the support of this group for this work.
Great. Any other questions? Okay. Do I have a motion to adopt the recommendation of the Child Health and Safety Task Force just presented by Mark?
So moved.
Do I have a second?
Second.
All in favor of adopting the recommendation, say aye.
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 All opposed? Hearing none, the adoption, the recommendation block has been adopted. Thank you, Mark, again, for all of that and your continued work on behalf of the subcommittee. We look forward to considering other recommendations in the future. Thanks again.
Thank you.
Moving forward, I'm finding my agenda here. Oh, yep. I think we've got Representative Devon on, I think somewhere in this universe. People, there he is. Representative Devon has been very vocal about our next presentation on strengthening Indiana families. Sure he'll have other things to add, but I'll, without further ado, move on to our presenters, Dr. Susanna Mariscal from Indiana University School of Social Work and Dr. Brian Victor, Wayne State University. Welcome and take it away.
Okay, I was trying to unmute. Hello, everybody. Good morning, and thank you so much for this opportunity to talk to you about strengthening Indiana families. My name is Susana Mariscal, and I am here with my partner, my colleague, Brian Victor. I am the director of the project, and he's the evaluator, and we're both associate professors at Indiana University School of Social Work. We're going to be talking about the strengthening Indiana families, and I am very passionate about this project. It was funded by a community collaborations grant for $2.74 million, 5 years. And this funding comes from the Children's Bureau under the Administration for Children and Families. And this is one example of the shift in paradigm in child welfare that is shifting away from a reactive response to a proactive response. So it emphasizes a proactive engagement of families, support for families, building resource-rich environments, and build on the strengths and protective factors for those families. We are operating in 4 counties. These are Delaware, Grant, Madison, Tipton. And this started as an idea between 4 people at a time. It was Heather Keshian from DCS, Gretchen Martin from Department of Health, Brian and I from the School of Social Work. We quickly invited PCAIN and Children's Bureau when we started thinking about the application for the grant. We saw similar interests. There were a lot of systems to be required to be part of this collaboration. So we invited FSSA, we invited a Corporation of Supportive Housing, Foster Success was part of this too. The commission started joining us, CASA and IU Health. And once we got the grant, we started building more connections at the state level, like with other universities, Better Hope, A Better Life, Rihanna's Hope, that is like a recovery kind of services, Indiana Library Federation, United Way, Riley's Hospital. So we kept expanding, and most of our work was at the local level too. So we started building partnerships at the local level with our coordinators. And from the 3 organizations that were originally part of the proposal, we grew up to 200 and more. So right now we have between 40 and 60 partners at every local implementation team. And you can see on the upper right, we have our partners from Delaware County. In the bottom right, we have Tipton County. Upper left, we have Madison County, and bottom left, we have Grant County. And it's been a fantastic group of people to work with. Our partners are just amazing. And we have this shared vision of creating a strong and caring communities throughout Indiana, where families have equitable access to the resources they need to be connected and safe. And this shared vision is absolutely focused on what I said, this shifted in paradigm. So we're really implementing 4 family resource centers that are intended as a proof of concept so that we can work on primary child maltreatment prevention and expand these throughout Indiana once we demonstrate, how this can be sustained. And our services are really focused on relationship building at first. We are emphasizing that engagement of parents. It's family driven, it's a strengths-based, culturally responsive, prevention-focused, and collaboration-based. There are several theories and perspectives that are guiding our work and are the spirit of our model: the strength perspective, resilience research, positive childhood experiences, and protective factors. And when we talk about protective factors, it's these 6 factors that are commonly found in literature around child welfare. When we talk about nurturing and attachment, this one is the single protective factor that comes around in every single study that talks about resilience. So it's caring relationships. It's that is experience that the child feels that somebody loves, the child feels safe and loved and protected. And that doesn't need to be only caregivers. That can be also mentors, coaches, teachers, anybody, any of you can be that for any child. Parental resilience has to do with the ability of parents to manage stress and overcome adversity or challenges. Social connections has to do with social support, and that's the informal or formal sources of, supports that may be informational, instrumental, emotional, spiritual, all those connections that help us thrive. Then we're talking about concrete supports in times of needs, because that is going to be reducing the financial stress of parents and increasing their well-being. So when we talk about these protective factors, we're also talking about the overall family well-being, not just the child well-being. And knowledge about parenting and child development is critical because to protect against child maltreatment, because many times parents may have very high expectations of what a child can do when the child is not ready to do that yet. Like, potty training when the child is 1. That is not, their body, their mind, their brain development is not there yet. And also another protective factor is social and emotional competence building among children so that they can learn how to manage their emotions. And this graphic is something that I developed when we were working on the application to try and show how all the systems needed to come around the families and what we were hoping to do. So we have the families at the center. In blue, we have all those systems that interact with the families on a daily basis. So schools, childcare, parks and recreation, libraries, health services, and law enforcement. So these systems are going to be working with families, and we hope to actually work with these systems and get referrals and collaborate with them so that we identify families before they need any formal involvement with DCS, before there is any report, so that we can work with all families in the community before any supports specifically from child welfare are necessary. In red, we have all those partners, system partners that were required to be part of the application. And we're gonna be connecting families with these systems once there are more complex needs. But what we're bringing is this soil, and we're bringing also the raindrops, right? So it's family resource centers that are bringing peer recovery coaches, concrete supports, legal clinic, parent cafes, and nurturing parenting program. Those are evidence-based practice, parenting and skills training, evidence-based practices. Community navigators, a window between worlds. That is a trauma-informed arts-based program for youth who have experienced trauma, a strengths-based case management. And I don't know how familiar we are with these programs, but many of them are evidence-based practices in different fields. So we're bringing them, let's say for mental health or public health, to child welfare to serve our families. Family fun event is a critical component of our project because we hope to create opportunities for families to build positive memories. Many families, many parents, you may be able to relate. We're on the go, go, go. One thing after another. We come from work, we have to put the kids to bed. We have to do the dishes and do that. There isn't really a time in which we can sit back and relax and just enjoy our children. So we want to create those opportunities. We're going to provide some food. We're going to provide some games, karaoke, crafts. So for families to be able to enjoy and just create those positive childhood experiences that are going to be essential in their future. We're also working through multi-system coordination, cross-system training. Kids Don't Come With Instructions is part of our public awareness campaigns, but it's going to be Kids Don't Come With Instructions, we're here to help, is really the idea of helping families normalize the need for parenting and skills training. We also believe that families come with their own strengths and naturally engage supports. And I love what just happened around insurance for children, because that's what we want, family-centered policies. So far, we have opened our centers in 3 of our sites, and we had a soft opening for the 4th. So these pictures are from Delaware and Brown County, and also for the soft opening of those 2. We had, for the soft opening of Delaware and Brown County, we had about 300 families show up for a drive-through event that we had in the middle of COVID. What we are offering at the centers is Susie's store, and our coordinators chose that name because they wanted, I mean, what we want is to empower families so that they don't have to talk about pantry or, you know, a place where they are receiving sort of help or that may be associated in any way negatively. So they can access diapers, they can have child safety items, hygiene, and in addition to food. But it's free take and make meals. So they have all the ingredients for a recipe. They have the recipe, and some of them they have a QR code, and they may have a video on how to prepare the meal, including the children safely. We have connection to resources, Wi-Fi, you know, a little lab there. Kids Corner, we have spaces for children in every, even in every room, we're trying to create them so that they can be engaged while parents are receiving services. Fun events that I already described, and service co-location. And these are some examples, some pictures of our centers, and we have their soft openings in Madison County that will be at the Y, Tipton County that is at a church, and Delaware County that is at we're sharing offices with another agency. So in terms of service co-location, we have a variety of services that range from career counseling, financial coaching. Now we added a lot of services to that. We have legal services. We are now collaborating with Indiana Legal Services and Indiana Pro Bono. And we are also providing tutoring services because that was a need that emerged very, very, very clearly during COVID, you know, tutoring services for youth. And it is really adapting every center to the needs of their community. So there are core components, but there are many, there will be many differences, or we're starting to see differences in the way that they operate. And there are many different evidence-based practices that we're providing, and much more is coming because we're shifting and we're adapting to what families are demanding. We have so far very good response from the community. And why did we do this? Why did we choose those counties and all of that? Brian will be talking about that.
Thank you, Susie. And I just want to add my voice in thanking the commission for having us here this morning. If you can advance to the next slide, Susie. As part of the, fortunately, sometimes with federal grants, you have to move straight to implementation. But with this grant, we were kind of gifted with a one-year planning period. And that really allowed us to make sure, you know, even though we were drawing on best practices from across the country in shaping these family resource centers and thinking about kind of one-stop shops for services and supports, we also were able to take 1 year and do a planning phase to ensure that what we were implementing was really specific and responsive to the Indiana context and specifically to those 4 counties, each one of which has important differences that we wanted to be cognizant of and responsive to. And so I just want to present to you a very small snapshot of some of our findings from that planning year, where we asked 3 important questions, we thought. The first of which was, where are families with children in foster care most likely to live within these counties? Again, the kind of goal and motivation for the Federal Children's Bureau was to fund primary prevention approaches to entry into foster care. So we really want to be cognizant of where families were at that were going into foster care. So here's, we just built out a heat map using data from Department of Child Services that looked at foster care entries within our 4 target counties. We really wanted to be attentive to place and thinking about locating those family resource centers in places of highest need. And so you can see from the map here that the areas of highest need usually centered around the county seats in each of our 4 target counties. So Tipton, Anderson, Marion, and Muncie. But even within Muncie, we were intentional about selecting a location for the family resource centers that was more on the south side in the 47302 zip code. So again, really wanting to be as close to the families as possible in order to be as responsive to their needs as we could be. Go ahead, Susie, to the next slide. And so not only thinking about location, but also thinking about the service array that we would build out at these family resource centers to make sure that we were attentive to and attendant to the kind of underlying determinants of foster care entry. That is, do we have the supports and services needed that are really going to address those family risk factors that might be driving entry into foster care. Next slide. And so we looked at AFCAR's data from 2019 across each of the counties to look at the primary reasons for foster care entry, so that when we were building out specific service arrays at each of our 4 locations, that we ensured that we were being responsive to that county's specific needs. Delaware, Grant, and Madison had very similar needs profiles. Of course, neglect was a major factor across all of those cases, but thinking about kind of modifiable risk factors, certainly parental drug use or parental substance misuse was a major factor driving over half of all cases in those counties. And so we've ensured that we have peer recovery coaches at each of the family resource centers, along with recovery support programs. And in fact, those are some of our the most well-attended services at those centers. So I think we feel really encouraged that this planning phase helped us to inform the services that would be at these centers, and that there's some good uptake among families for that. We also did a series of interviews and focus groups with frontline service providers to get a feel for what, again, the underlying determinants or drivers for foster care entry were in the target counties. And you can see the list here. Perhaps unsurprisingly, substance misuse, domestic violence, trauma, and mental health concerns. And so at each of the centers, we're trying to think about innovative ways to address these for families, but again, ways that are destigmatizing and that really draw families in where they choose to come to these centers. Next slide. And then lastly, we asked what barriers exist to the receipt of effective services and supports. That is, if these services and supports may already exist within the counties, where might the disconnect be between why families are choosing not to use those services or potentially unable to access them? So next slide, please, Susie. We found 3 major themes. First, families were often unable to access the services and supports that would help to build up those protective factors that Susie mentioned earlier. That is, in many cases, the needed services and supports may not have been located in the target communities, or they may have been within the county, but at a sufficient distance to make it very difficult to access those services. Again, why we wanted to think about place as a very important aspect of where the family resource centers were located. Services may be cost prohibitive, which is why in many cases we are offering those services free of charge. I think nearly everything that will be offered at the family resource centers will not have an associated cost. And then there may be long waiting lines for services in targeted communities. So this might mean the family resource centers can help to expand the service capacity within those target communities and help to alleviate or reduce those long waiting lines for services. Next slide. Our second theme was kind of families were unaware of available services and supports. That is, there's great work being done in the various counties, but families weren't being connected to or made aware of those. And so I think we're very hopeful, and I think we're starting to see some benefit from the co-location of services and for our cross-system collaboration work. In each of these counties on a monthly basis, we've got 40 organizations coming together to support the Family Resource Center, but I think that has a spillover effect in helping different organizations to be aware of the services and supports that are available at other organizations in addition to the Family Resource Centers. So I think we're seeing a lot more cross-system collaboration and communication that helps to then bring that knowledge to the families about what is available within their counties. But I think we also envision the Family Resource Centers as kind of a first destination. They can arrive at the Family Resource Center in a friendly, welcoming way, and then learn about all of the different supports or resources that might be available in the community. And ideally, it might be co-located there for them to access right away. Okay, and then lastly, and I think this is very important to the way that we're conceptualizing and operating the Family Resource Centers, is that families oftentimes choose not to access services and supports. That is, there's a lack of trust potentially between service providers and families, or there's a high level of stigma that's associated with the receipt of social services. I think this is really where we put a large emphasis on family fun events and activities like the Kids Corner. That is, we want families to kind of in their mental mapping of their county, see the Family Resource Centers as a place where they're choosing to go because they're received warmly, because their kids say, oh, we want to go to those family events. Kind of this low entry point, and then having deeper end services available if and when families elect to receive them. So we really kind of want to shift the focus and not have these be seen as simply social service centers, but really as places where families come to create positive childhood memories and to thrive. And with that, I'll turn it back over to Susie to wrap us up.
Well, that's really all what we have, and here's our information in case you want to contact us. And I think that you will have access to our slides, so you have the address for each of the centers if that's in your communities, or to share if you know anybody there. But we really appreciate this opportunity to talk, and we'll answer any questions that you may have.
Hi,
Can I
this
ask a
is,
question?
go ahead, Representative Vaughn.
Sorry. How were you
Yeah.
received in the communities, coming into the community? How were you received? Were they a little skeptical themselves as far as all the providers, or did they embrace the concept of what you're trying to do?
Initially, it really varied. Some communities received us quickly and engaged from day one, but I would say that maybe 3 of the communities were a little hesitant, and we're not sure what we were trying to do. Once they understood what it was, and that was all the work from our coordinators, they're fantastic people. They really were able to engage the partners, and they're all on board. And actually they understand how important it is, the cross collaboration, the co-location of services, because they are now the ones that they're coming and volunteering in addition to their time, many of them, in addition to their work responsibilities. Sometimes they're coming in the afternoon to just, fill up packets, because we're going to have a big event with children, and crafts and kind of things. And some people from the libraries, for example, volunteer their time, or childcare providers volunteer their time to do children's specific activities, because we're planning something for the parents. So it's really, or the family fun events, that's where all the partners love and come together. So it was it took a little work in some communities to clarify that we're not creating a new agency that is going to be competing with them. We're actually creating like a collaboration, right? So this is more like from the model of collective impact, right? So we're all coming together to put something, so everybody contributes to this for the benefit of the community.
Great. So when John Hammond opens this up to every county in the state, you're ready to administrate it all?
And something I have to add, something that is really satisfactory is to see providers bring their families to the family fun events, because that was something that we were hoping to create, a space for everybody in the community. And if providers are bringing their kids to family fun events, or to the soft opening, for instance, they brought their kids because they knew that there were going to be fun things to do with the kids, right? So obviously that means that that's the true spirit. It's everybody in the community has a role, and every parent in the community is supported, like that they can feel that they're supported by the center.
So your main mission statement is to put Terry Stignan out of business as well.
Well, Terry loves that. So Terry has been very supportive from the beginning. So
Susanna, we're on the same page.
yes.
Susanna, this is Chris Box. I'm State Health Commissioner. And as you know, we have an OB Navigator, now known as My Healthy Baby program,
Right.
already rolled out in 22 counties, adding 25 this year. I'm getting ready to get back on the road with that with Jen and Terry. But I wanted to say that 3 of your 4 counties, Delaware, Grant, and Madison, all have My Healthy Baby programs, which the concept is get women when they're pregnant and their partners, engage them with a community health worker, nurse family partnerships, healthy families, whatever providers are available, and then follow them through the pregnancy and the first year of the baby's lives. And a big part of what we've been talking about is what is that transition that we can connect them to, so that at the end of that year, there is ongoing support and resources at something like what you're doing. So we'd love to put you in connection with those groups in those communities and see what we could work out, because I think that their introduction as a pregnant early family to the Family Resource Center would be an ongoing support system going forward.
Absolutely. I love this idea. We connected with the OB Navigator coordinator before we opened the centers, like the state coordinator. But at that time, it was a hectic time for them and for us. So we did connect and we said we need to follow up later once we have things going on. So absolutely, I think that it's critical. We do receive a lot of referrals from healthy families. We're working very closely with them. And you know, our implementation team comes from the Children's Bureau, Inc., right? Mm-hmm. So we're receiving a lot of referrals also from community partners for child safety. So, however, we are, yes, we need to do more. And just to mention one of the programs that one of our partners is implementing in Delaware County, actually, it's called Child Time. And it is establishing a cohort of parents with infants, mm-hmm. so that they learn developmental, child development, but also strategies to stimulate the healthy development of their kids. So, and they go together. The hope is that they will go together for 5 years. So that means that we are not just creating healthy development for the children, but also informal supports for the parents, mm-hmm. that will be critical in times of need, right? When we cannot really, with our coping skills are not really working, it is easier to call this parent if I have a trusting relationship with them, right? So
love that. Mm-hmm. That's awesome. If you have a minute to send me an email, or I can send you an email, I'd love to try to more formally solidify that connection, because absolutely. I think that if this is going to grow in the state of Indiana, I want to make sure that all of those resources are put together.
I will. Thank you very much.
Thank you.
And by the way, I have to say you have a fantastic person in Gretchen Martin. She's been our solid partner since the beginning.
Awesome, Susanna. I'm glad you guys have connected. Thank you.
Thank you.
Good morning, Susanna and Brian. Thank you so much for your presentation. I'm the Secretary of Education, and a couple of things here. I noticed that our logo was not an official partner yet. So I want to first and foremost lean in and offer, we would love to connect our team with you so that you can share the work you're doing, what you've learned, and then to Representative Devon's point, how we might consider scaling what works. Yes. So appreciate hearing again the work you're doing for our families. We know that they are just a key part. You mentioned the two. I mean, I have a long list of notes of all that you mentioned, and I too would appreciate a follow up, and we'll connect you with the right people so the Department of Education can be a partner.
We'd love that, because we're partnering at the local level with different school systems, but we would love to partner with the Department of Education, because that's the everyday, right? So if we're thinking of scaling up to the state level, we really need to be including you for sure. Thank you so much for this connection. Really appreciate it.
And we know the learning gaps that we're seeing, that we have seen, and that are going to be exacerbated, and also with the educational attainment gaps that we have, our families, our schools can't do it alone, and our families are absolutely key in engaging. So yes, I look forward to it. Thank you for making that connection.
And just to mention the tutoring program that it's an IU program that operates throughout the state, is going to also provide a mentoring program. So it's not exactly like, Big Brothers, Big Sisters, but it's a mentoring program so that parents can also be involved in that tutoring. So it's a very interesting program. It's a shout out to them too. It's fantastic. Great. They just received a grant from you, so they're very excited because they will be offering more services. Yes.
Thank you. We'll connect more then.
Awesome.
Susanna and Brian, my name is Bernice Corley. I'm the Executive Director of the Indiana Public Defender Council. Thank you for your presentation. It was fantastic. I feel so uplifted and encouraged today. This meeting has just been fantastic. As I was preparing though for this meeting, when I looked at your materials, it reminded me of something that I read So I read the 2019 Child Abuse and Neglect Fatality Report. And at the end of the executive summary of that report, it pointed to many stressors that caregivers and families were experiencing. And just to read the line, it said, in some cases, caregiver stressors were determined to play a role in the death of a child and neglect also. Insufficient income, unemployment, and substance abuse were frequently cited as stress factors among caregivers. So I know that's no surprise to you two, but my question is, based on the work that you're doing, what data are you collecting to demonstrate that your work is relieving those stressors and hopefully preventing, reducing cases of child neglect and abuse?
Brian, do you want to answer that one?
Yeah, sure. So we'll be measuring just across kind of the various services that we provide. We have measures that are very directly connected to the protective factors framework. And so we'll be looking at instances where we're increasing those protective factors, but also decreasing the risk factors among the list that you just noted. So we'll be looking to the extent that some of the services decrease trauma symptoms, for example. So across that, kind of in the short term, we're looking to see, do protective factors increase and do risk factors decrease? But then we'll also be measuring at the county level whether or not having a family resource center in the county decreases the rate of child maltreatment reports and decreases the rate of formal child foster care entry as well. So we'll be documenting both of those things through the outcome evaluation. And then we're also going to be running a process evaluation that helps us kind of collect those lessons learned in terms of implementation so that we could share that out throughout the state for other communities that may be interested in launching and establishing these family resource centers. So hopefully we'll have some good data by the end of this to share with others, both on effectiveness and implementation.
In terms of effectiveness, also, I don't know if you mentioned, we're tracking hope, and we are like for those families that choose to enroll in nurturing parenting program, because it's available for free for any family in the counties. But sometimes it's hard to engage parents in 14, in a curriculum that lasts 14 weeks. So to work with if families, if we get there, we'll be also assessing parenting skills through solid measures. So that actually identify the risk for maltreatment. So that would be
wonderful. Well, we look forward to a report back, and I want to follow the trend. I would love to connect with both of you after this meeting. Public defenders have received funding to work with at-risk youth and families, and we would love to partner and take whatever positive lessons you all are learning and try to reverberate it as best we can help. So thank you both.
Awesome. Thank you so much. Because we saw an increase in referrals to truancy, and that will be a fantastic partnership, especially to work with you. Thank you. This is so excited. Seriously, it's like Christmas morning. Love it.
Brian and Susie, give us a sense, because I think and Bernice sort of hit the nail on the head. The outcome data that you're discussing, what's the timeline on that? I mean, essentially, I don't think I'm going out on a limb. We'd love to have you back to at least go over some of that with this group, but what is the timing on that, just so we can sort of earmark that in our heads? I know you're gonna have some individual engagement with different folks on this commission.
Yeah, we'll have, in terms of the outcome data, we're probably a year or two out from having solid figures in terms of the outcomes. Process data will kind of be forthcoming. So at kind of each stage of the process, we'll be documenting lessons learned through kind of launching, installation, and then implementation. But outcome data, I would say 1 to 2 years.
Great. Well, there's obviously a high level of interest and already participation, whether it's on the learning loss side or with DCS and the other partners that are already on this call. So we'll find ways through Julie and others to have regular sort of engagement with you all.
John, I know we need to move on, but I know there's other states that have had this implemented, and I don't know if we're connecting with those other states, Brian, or not, but I'm assuming they've got some of that data that would probably be relevant to what we're doing here.
We can share actually, Julie, because Julie has been a fantastic partner. I mean, like she's been in every single meeting of our steering committee, and she's been helping us, steer and identify excellent resources. Julie, we can share the New York presentation, and we have other Florida and data, and also data from Allegheny County. So Allegheny County has been implementing family resource centers for 30 years. And Florida for many years too, and New York in 10 years. So a huge transformation. Of course, we cannot say that, prevent only reason for that transformation, like that huge decrease in foster care entry. However, it's exactly in the neighborhood where the family resource was implemented, right? So that's where you see that. So we can share those presentations with you. And yes, we are connected to all the, there are in total 13 grantees, 9 from this round and 4 from the other one, from the previous one, that are receiving this grant. And there are other states that have been implementing this model too.
Can I ask a question?
Yes.
Are you doing an ethnic breakdown on the different areas?
Yes, we will collect data based on race, and then kind of stratify our results there. Really, we just actually got some supplemental funding from the federal government for.
We applied.
We applied. We have an application in for some supplemental funding for race equity, and thinking about being very intentional within our family resource centers of how we move that forward. So yes, that will certainly be a component of it.
Well, not seeing any more questions or comments. Thank you. Obviously, I hope you can tell we're excited by the work and what you're sharing, and obviously anything you share with Julie, we'll eagerly await. Representative Vaughn makes a great question. There may be some a little ahead of us, but you are doing incredible work on the ground, on the front lines, and I think that I'm excited to see what comes out of some of these individual conversations as well, in addition to the commission being hopefully a platform to continue to engage and help expand really critical services. So thank you
so much,
Doctors Victor and Mariscal. Thank you very much.
Thank you so much. And I have to give a shout out to Terry Stickton and her agency. We have representatives in our steering committee at every level, like from local office directors, regional office directors. We have Heather Zikeshian, and Terry herself attends some of our meetings. It is a privilege to work with them. And frankly, to have the support, even monetary support, because they support us even through community partners for child safety. So thank you everybody who supports us. Peggy Welch is fantastic. I mean, I could name so many people. Thank you so much.
Well, we look forward to talking to you soon. And again, thank you for the time and entertaining all our questions and interests. So appreciate you both. All right, next up, and with an action request to follow, we've got joining us today, I believe, I'm looking at my panel here, Maureen Greer with IPQUIC, and Susan Ellsworth, who will present, and then we will on mental health and from the mental health and substance abuse strategic priority, and I think we'll be taking some action potentially on a new objective related to that. So, Maureen.
Great. Susan and I have a very hard act to follow. But we appreciate the work that we listen to, and we hope we can challenge you with an equally interesting and a population that needs attention dramatically. Next slide, please. The Indiana Perinatal Collaborative, which I have the privilege of directing, is really focused on the prenatal through up to age 1. So really looking at birth and postpartum issues. We were charged by the General Assembly in 2014 to look at the issue of substance use and the prevalence of substance use prenatally and infants that were born with substance exposure. Up to currently, we have 70 hospitals conducting screening, cord tissue testing, and treatment within the hospital, and then looking at discharge. We also have developed a toolkit that incorporates a standardized evidence-based approach. Remember that the General Assembly passed 2 years ago requirements for prenatal screening for substance use. We've recommended to our prenatal care providers a screening tool called the 5 Ps that not only screens for substance use, but looks at depression and domestic violence as well, as we know that those are comorbidities. We've provided educational opportunities paid for all of our hospitals and expanded the opportunity for participation in that education to our First Steps, the state First Steps program, to home visiting programs, as well as to child welfare services, child services. We have really enjoyed and depend on cross-agency activities to support pregnant patients with substance use disorder, and to really look at this from a public health perspective and not as a criminal justice issue. And we think we've been pretty successful in working at this issue. One of the issues that Susan and her colleagues at Indiana NOFAS have continued to raise to us is that the 10-panel drug screening that we do does not include alcohol or tobacco, and they're particularly interested in alcohol. And so last year, next slide, please, we established a fetal alcohol syndrome disorder work group because, as Dr. Box reminded us, that we can't be looking at marijuana and opioids, et cetera, and not pay attention to those alcohol and tobacco issues that we know affect a much broader population than some of our other substances. So we charged this work group. Susan and her colleague, Kelly Welker from the Department of Mental Health and Addictions, chaired this work group for us. We had representatives from all levels of our Indiana delivering hospitals, representatives from child welfare, from mental health and addiction services, to really, and charge them with looking at a standard definition for fetal alcohol syndrome disorder, a uniform process for prenatal identification and neonatal identification, which is really the scope of work for the collaborative, to look at what appropriate resources were available to support providers, and to develop a toolkit, again, much like the other work we'd done around substance use. And then to develop recommendations for the Governing Council to address the needs of this population. They do have a series of recommendations that will go to the Indiana Collaborative Governing Council next month for their action. But one of the key issues that we identified, and that's why we came to Julie and we are now presenting to you, is that in some ways the work that we're doing in that prenatal and neonatal period is the easier part of the work related to fetal alcohol syndrome disorder. And that the real challenge, which Susan's going to talk to you about, is those older children who aren't identified by that screening process at birth, but have the results of alcohol consumption during pregnancy, but were never identified as that. And there are no screening efforts that specifically ask questions about, did you drink while you were pregnant? So we've ended up with a population of children that fall outside of the scope of the collaborative, but have tremendous needs in terms of both screening, identification, and treatment. And so I'm going to ask Susan to present from here, and then I'll come back at the end with our specific recommendation.
Thank you, Maureen, and thank you, Commission, for allowing us to speak today. I know not only the Executive Director of Indiana NOFAS, I'm an adoptive parent with real life experience and can speak to how this unpacks me personally and my family and the families that we know. So some of our barriers to addressing FASD is a general lack of knowledge. What is it and how does it affect an individual and the potential of what they could have accomplished without the effects of alcohol consumption during pregnancy? As Maureen mentioned, there are inadequate screening processes, both pre and post-delivery. And we're often missing the diagnosis at all, or we're misdiagnosing it. Child may be diagnosed with ADHD or another neurodevelopmental disorder. Establishing a prevalence is cumbersome for Indiana because of the way that we currently establish the prevalence. And the barrier there is with the number going back to 0 to 5. We use our Indiana Birth and Problems Registry to collect this prevalence. So if a child is not diagnosed between the ages of 0 and 5, then it will never add to our prevalence rate. And this is problematic as most individuals aren't diagnosed during that time period. And also funding is a huge issue. We spend a lot of money in the state of Indiana addressing our illegal substances, and yet it is our legal substances of nicotine and alcohol that have the most long-lasting effects. And the normalization of alcohol use. In America, we are a country of drinkers. It's part of who we are. It's built into all of our movies. It's built into all of our TV shows. And so we do a lot of sports watching with our kiddos on the weekends. And one of my sons was out singing the ditty to a beer commercial. And I'm like, dude, you know what I do for a living. And he's like, it can't be bad, because if it were bad for me, the commercial will be on at nighttime when I'm in bed and I can't see it. So he's made this connection piece. And then as the industry has started to include kings and castles and normal objects that children play with, we are raising our next generation of drinkers. Next slide, please. So some of the services that really need to be in place is we need to have appropriate and adaptive behavioral supports. The people that provide those behavioral supports need to be informed, and there needs to be some flexibility in those models so that it takes into consideration the cognitive impairments for those who have experienced prenatal alcohol exposure. Our mental health providers also need to be informed of how this affects their development, how this affects their ability to respond to the supports that we put in place. Our educators need to be equipped with flexible tools. How can they reach the needs of the children that are in their classroom to enhance their learning, to help them be efficient educators? And I loved the slide from our last presenters of the flower and all the different community partners. All of the community partners that you saw in that flower that touch the lives of families and children need to be aware of the effects of prenatal alcohol exposure and how that impacts their development and their potential on the structure that they're going to need. As well as our individuals need the opportunity for positive community engagement. Those community partners and engagement opportunities that will allow the neurodiverse population to engage, to, I dislike using the word normal, but to engage in what we would consider normal community activities for families and children. Next slide. Without those services in place and on our current trajectory, we are going to continue to stress our education system with IEPs, 504s that have to be managed by our educators and staffs. Our suspensions and expulsions are going to be impacted. Often this population of people, because they have a disconnect between their choices and their consequences and can be very impulsive are considered to be non-compliant in education situations when really it's a capacity issue. And our current method of dealing with that is punitive. We're going to tax our child welfare systems. This population of individuals are at increased risk for entering the child welfare system. They are at increased risk of abuse and or neglect. And once they are in the child welfare system, it becomes increasingly difficult to find appropriate and adequate placement that meets their particular needs. Next slide. Our mental health centers, it's no secret to those of us in this meeting today that we have a shortage of mental health providers, especially that provide services to children. So as we have more individuals who are exposed to alcohol entering our mental health centers, this exacerbates that problem. And it also leads to a stacking of disorders because we're not identifying early on that the symptoms that we're treating in our mental health centers are really a result of that prenatal exposure. And we have an increased risk of suicide with this population. This population also is at higher risk for substance use, and it escalates to addiction at a much higher rate than their typical peers. And again, because of the disconnect between choices and consequences and impulsivity and difficulties in self-regulation, this population usually enters our juvenile justice systems at an earlier rate. The average age is 12.8 years for their first encounter with the police departments. And it's difficult, and once they enter these systems, to find appropriate venues for addressing the behaviors that we're seeing in a way that takes into consideration the capacity of the person that we're making decisions for. Next slide. Maureen, you would like to pick up the request?
Sure. Thank you, Susan. I think the challenge that we face, and we're not asking you for solutions right now. What we're asking is that you explore what the issue really is. We'd like to be able to come back in the next 12 to 18 months and be able to present like Mark did around the challenge that he brought you. We know we have a handle on what happens between prenatal and one, in the sense that we have systems in place. We have a process in place now. We are implementing those strategies. What we don't know is after age 1 and through the age of 21, how many children have never been diagnosed. We know that as Susan said, they act out in different ways, that if we had a better handle on identifying the root cause of their issues or behaviors, that we would be able to better intervene, more appropriately intervene. So what we are asking today is that we add to strategic goal 2, which is increase access to quality mental health and addiction services for children and their families, a new objective, which is identify and encourage adoption of screening protocols and promising treatment options for children with substance and alcohol exposure. We actually, Julie asked us to prepare a new objective. We actually prepared an objective for every single strategic goal. But it seemed to us, as we really laid out, that strategic goal 2 was the most appropriate place to put it. There aren't really good developmental screening tools, and it's not the natural thing once a child enters school around development. So mental health and addiction services really, we believe, provides the best opportunity, most optimal opportunity to actually be able to sort of get your arms around this issue and to be able to come back with good data and recommendations on how Indiana can move forward to address this real population, not just that child, but their family and the impact that has. And as Susanna was presenting, I kept thinking of, this is another population that could really benefit from the family centers and the ability to enter a trusting relationship and receive the kinds of wraparound services that they need to be successful.
we have any questions for Maureen or Susan? Seeking a motion to adopt a new objective related under this for that strategic objective. Pardon me. Do I have a motion? Do I have a second?
Second.
Second.
All in favor?
Aye.
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 Opposed? The action is adopted. Thank you very much, Maureen, Susan, and look forward to hearing back from you on that new objective. Next up, we've got joining us, just to frame this a little, and I believe I'm right, Julie will certainly correct me, and she might even be going a little into this in her update after this. We're going to have, by statute, thanks to members that are joining us from the General Assembly, of course, the governor signed it, foster youth joining us on the Children's Commission, which is extremely exciting, something we talked about for a little while. Of course, had former foster youth, current foster youth join us at different junctures. But this is really exciting. We're currently going through a process that we've set up to of selection and vetting. Then the governor will make appointments. And hopefully, I think this is right, in person then next meeting, we hope to be joined by those members. So Julie, if I'm wrong on that, correct me, but if not, in anticipation of that, we thought this presentation next by Megan and Justin from Foster Success on effectively integrating those members into our Children's Commission would be really beneficial for all of us moving into that next meeting. Please enjoy, and then after, just directly following that, Julie, you can just go right into your update. Megan, Justin, welcome.
Thank you so much for having us. I'm Megan Tribble. I'm the Director of Youth Engagement at Foster Success. And I have my partner here, Justin Hayden, who is part of our Indiana Youth Advisory Board leadership team. Justin, you want to say hello?
Yes, good morning, everyone.
Morning.
And so we are here today to talk to you about authentic youth engagement and how to integrate these new youth members into the commission. And so when we talk about authentic youth engagement, what does that mean? The definition, the full-on definition, is young people that are actively and authentically involved, motivated, and excited about an issue, process, event, or program. So that's a lot of words, and so we'd like to break that down. And so authentic, we look at engaging young people as being authentic. And so in order to do that, we have to address any of our adult attitudes or beliefs towards youth being involved in these types of, whether it's a commission, whether it's program development or boards. So we look at the spectrum of adult attitudes. And so one area is seeing youth as objects in a space that youth are recipients of a program, or it's their responsibility to take advantage of a program that we've developed for them because we think this is what's best for them. We think it's what's good. And so they now need to take their responsibility goes into taking advantage of this program. And we also look at youth as recipients in that we create a program and we create these minor areas where youth can make decisions, but they're not truly designing a program, they're not truly impactful, but it's kind of like that pat on the head and here's how you practice for real life. And so then the adult or the youth are then put in a position where they're to take ownership and make these decisions because it's going to help them later in life. But what we love to see is youth as partners. And so youth as partners really looks at the adult and youth relationship as equal. And so we involve them in all aspects of it. We take the time to prepare them. We take the time to find common language with them. And so the young people then have a responsibility on themselves to make sure that they are educated and that they are taking advantage of opportunities to learn more so that they can have a seat at the table and make informed decisions. And then as adults, we respect the young people as having something significant to offer, and we support and encourage their full involvement. So authentic also means being having that true partnership. And so when we have a true partnership with youth, it is important, especially youth from foster care, And that's the realm that I'm speaking from, because that's my area of expertise is foster care, but is that we are preparing them, especially for these higher level decision-making opportunities and to be upon the commission, is so that they know why they're here, what the purpose is for them being here, and that why are they needed? And then what is their role here in the commission? There will be a lot of times where youth will say, will see themselves as less than, come into a room like this, even if it is on Zoom, and be very intimidated and think that, okay, I'm not supposed to talk, I shouldn't say anything. And so it's important that we're preparing them prior to the meeting to say, this is why we want you here. This is your contribution. This is why you're needed. And so it's also important to let them know how the process will unfold. And so while a lot of our youth have gone to meetings, sometimes agendas can be different. Agendas can look different. The way meetings are ran can be different. And so it's important that they understand the process of this commission and how the meetings flow. Now, having said all that, that takes a lot of time. And I can absolutely attest to that, because that is the bulk of my job, is doing a lot of preparing, a lot of debriefing. And then the meetings that we actually go to are a very small portion of what I actually do for my job. And Justin can attest to that as well, because him and I have met I think we've met 3 times to prep for this meeting. So, it does take time, and we value that. And so, but if we didn't take that time to go over the presentation together, then that would not be fair to you all as recipients of our information, and to Justin, who would probably feel like completely out of the loop and not knowing what was going on. So it does take time, it does take effort, it does take work, but the payoff is well worth it. So I mentioned debriefing, and that is also something that we do after meetings like of this nature, or after conferences. We always take time after the meeting to just talk and say, did you have any questions? How did you feel about this issue or that issue? And a lot of times that's where you'll find out where the youth may say, I have no idea what you guys are talking about, and so that's a good opportunity to really help educate them further, so that they do feel, again, a partner and are able to really have a voice within this commission. Common language. So having worked in child welfare for almost 20 years on the provider side of things, I speak in acronyms. And so it's a whole nother language. And so a lot of times whenever we have new youth on our board, they will be like, I don't know all those letters. What are you talking about? And so it's also true with whenever we have new staff at Foster Success, I always tell them, when we start speaking in acronyms, please stop us and let us know, to explain that. And so I'm sure it's the same here, a lot of acronyms, a lot of terminology that is very common to us, but to someone, even though they are recipients of these services, they do not understand the acronyms and all the lingo and jargon that we use. So it's important that they have either the opportunity to debrief or have some kind of preparation before that, so they are able to speak the same language. And so again, with youth engagement.
They're not the only ones though, Megan.
Yeah, I'm sure. And so yes, it's also very important for the youth engagement piece that you have youth that are motivated to be here, and that they're not youth that are just like, hey, you look like you would do great on this commission, come on aboard. That we really educated them on what the commission does and how awesome this opportunity is and what kind of impact that they can have, so that they are excited, so that they are motivated to come. Because when we don't do that and we don't have the motivation factor within the youth, then that's when we see a lot of youth that drop off of these types of opportunities. And so it's important to keep the hype up and to let them see the results of their work. And that's one thing we've really been working on within the board, within DCS, or with our partners at DCS, is just really closing that feedback loop. You've given us your voice on so many things. We took it to this person or this agency, and look what happened. Because a lot of times they're not able to see the results of what their voice has done. And so having said all that, I'm now going to turn it over to Justin, who's going to talk to us about some youth adult partnerships and some characteristics of some very successful youth adult partnerships.
Yes. So as Megan mentioned, when you have true authentic youth engagement, that definitely leads to more successful youth adult partnerships. And that provides extremely amazing opportunities for both parties, because you're just simply learning from each other all the time. You're able to utilize each other's skill sets, make more precise decisions, and you're able to independently carry out tasks to reach shared goals, which kind of comes in where that concept of mutuality kind of comes in, because you're able to distinguish from youth adult partnerships from that parent-child or student to teacher or mentoring like dynamic, which definitely will make the work that you're doing much stronger than it would be if you were developing it with just one partner. I also think it's important to mention that, of course, we know that this work is very beneficial for youth and young people because, of course, this helps with positive youth development. We know that they'll gain a lot of skills and experience working with you all. And of course, they can put that on their resume, which can lead to future opportunities. But it's extremely important for you all as well because young people offer these fresh new ideas. They come with these new perspectives. I know in the foster care system, we have this saying, nothing about us without us. And what that simply means is you can't do something for me without asking me what it is that I need. So they come in with a whole new like lens of things. And I think that's really important for the work that we do. They also come with additional resources when it comes to shared responsibilities. Megan Tribble, she is the lead for our Normalcy Conference for Foster Success and our Youth Advisory Board. And that's a lot of work for one person. So me as the Normalcy Outreach Coordinator, I assist her in that. I come with my own skills and connections, and I actually helped found our keynote speaker for the event. I actually also worked with Director Stigdon, where she was able to provide us with an amazing video presentation for the conference that absolutely knocked me off my feet, and I cannot wait for our other youth to hear it. Also, having youth partnerships means greater credibility for the program and the work that you're doing when it comes to them expressing that with other young people and other advocates who may also be interested in joining. And now I want to shift gears a little bit to talk about like ways we can support these young and adult partnerships, because transitioning into any new space can be a challenge of some sort. And I'm pretty sure you've all already thought about this. So I'm going to keep it brief. And that starts with expect no more or less from these young people. I know how that may sound, but it's very important that we are careful with our intention setting, because even positive expectations can lead to like not so positive outcomes. Which kind of goes into my next point, is being respectful of their times, their responsibilities. You're most likely going to be working with youth who go to school, go to college. They either have families, they have jobs, or they're most likely in a sport probably. And so making sure that they're aware of meetings and events and what time they're happening is very important, because they most likely will not always be available during the regular business hours. Next is treat young people as individuals. They're going to bring to the table their own experiences, their own skills. I'll use myself as an example. I'm a former foster youth, but I am not the voice of all foster youth. I come with amazing skills and an amazing experience, but it's not the experience of all. So we're making sure that we're being mindful of that. Megan kind of mentioned it earlier, taking the time to like explain and like open space for questions. Again, there's abbreviations and things and technical jargon that I still am not aware of. And every company, every office space, every industry, they all have their own like little like dynamic as to how we say things. So definitely leave room for that. Another one is planning for young people's involvement before they enter those spaces. That includes like the prep time and making sure that they're aware of what's going on and what's happening. And lastly is just covering that, make sure that we're taking note of the internal and external barriers that we have. Megan kind of mentioned this as well, being mindful of time, the transportation, availability. And one thing that is very important is the lack of understanding of what's happening in that moment, because that can end up leading to like disinterest in what's going on, or even like that lack of belief in their own skills and abilities and what they can contribute to this work.
Thank you, Justin. And so we've also given you a handout on strategic questioning. And so we talk to the youth a lot about strategic sharing, but it's also important that when we are asking youth to be involved or to speak about certain things, that we're cognizant of a few items as well. And so, one of the main things is just being upfront on why we're inviting youth to this group, sharing the purpose of why they're why this legislation was passed, to include them, why they're important, why they're needed. And so then also to get even more specific, but what is the purpose of the agenda? What are these agenda items? Why are these things that the youth need to be involved in? And so just explaining those whys. I'm a big believer in the why. And so it's so many times we're just, as adults, we just say, well, this is the way it is. Well, this is the rules. But when we take that extra step and explain the why, it can make all the difference. And so it shows that we are trusting youth to understand and to process that information, and then to remember it moving forward. And so the why is always a good place to start. And so there is also, if youth are being asked to share any parts of their story, or they start to share parts of their story, it is important to allow them to be authentic with that. And that we're not encouraging or discouraging any type of changing within that story. And so the other part of that is just that youth are well aware that if there's an opportunity or potential that they may share parts of their story, parts of their history, their lives, that they are aware of who's in the room, whether there's media, whether it's recorded, whether it's being written down. And so then that way they have full understanding of where that information could go. And so we have had youth that have talked with the media and then realized, oh, wow, they really do write down everything I said, and so it was really, that can be harmful in some aspects. And so, family dynamics within foster care specifically are always, they vary all across the board. And so, you could have youth that are still very much involved with their biological family. And so that can lead to hurt feelings and all kinds of different other family dynamics. You could have some youth that have not seen their bio family in years, and those types of things don't really bother them. It's just that we never really know. And so we just try to protect all the youth, no matter what their situations are. And so then we also just have a couple examples whenever we, it's not just with family dynamics as well, but it's also people in positions of power. And so within this group, the youth may feel, a certain type of way about not wanting to share just because like, oh, is that Director Stigdon? I think she's pretty high up, in DCS. And so, we want to also let them know that it is okay. It's safe to do this. We had a training where the leaders went to, well, they didn't go, they were on Zoom, but we trained a bunch of the DCS workers. And so in the audience, a lot of their own workers were there and their IL providers were in the audience. And so at Foster Success, as we were prepping these youth for that presentation, I made very clear to them that these people would be in the audience, so whatever you say about them, to them, what have you, they are going to hear it. And so, a lot of them were like, oh, that's fine. We have a good relationship. But, it's one of those things that there are these positions of perceived power. And so whether that person actually has power or not, the youth will look at them as someone who has power, and they will alter their responses to that, whether that person actually has power over their lives or not. And so it's always about the true power and then the perceived power that the youth may see as well. So because youth in foster care have been in such unique situations, a lot of times they may alter their situation, or they may alter their responses or their views based on what they think you want to hear. And so it's always important that, we allow them that space to process and really think about their own views, and not just going back into that people-pleasing mode that they may have been in childhood. So, but I think that is all we have. And so we want to leave just a few minutes for questions if you guys have any. And Julie, if you'd like to share anything else.
I would actually, because there's one other important tip that I don't think you covered, or you might have covered it very quickly, but it's been one of the really kind of a North Star to me as we've dived into this work with youth with history in various systems, right? And that is when we are asking questions that you kind of hit on it, Megan, but that we're together for a purpose that's more future focused. And so when we're asking about their experience, it's really as it relates to whatever topic we're talking about, or we're looking for their perspective on a solution. We're not necessarily wanting to delve into the past because we're curious about it, right? That there's kind of a respectful way to keep those questions future focused. I didn't hear you mention that. You probably did, but I don't know. That was a really
I
important
appreciate
one
you bringing that up. Yes.
last year.
No, I do. I appreciate you bringing that up, because absolutely, that is something that we all need to be considerate of, is that a lot of the youth now within their roles within IAB, within all these other boards, they are no longer talking about their past. And so they are future oriented. They are moving forward. They are looking at how can I make changes moving forward. They're not really looking at specific things that happened to them in the past. And so they may be using their past experience to guide their advocacy work or to guide their views, but that is not a topic that they have ever, that they're willing to talk about, and nor would we ask them to. And so it is kind of a cool thing though too, is because whenever youth, especially in the foster care system, they go through all these workers and providers and who are asking them, what happened, let's deal with what happened. But when they get to this stage in their life, it's not about that anymore. It's about, where do you want to go? What do you want to do? And so that's how we focus things, you know, within this older youth realm. And so, yeah, I think that it's just great seeing that shift in them as well, that we're not interested in the past, we're interested in where you want to go.
I know Justin has to get to work here shortly. Does anybody have any additional questions for Megan or Justin? Now that I scared you all into not asking questions. Okay, should I go ahead and do my update then, John?
Yeah, that'd be great. Justin, Megan, thank you. Your timing was good, both before this next meeting and then inside of this meeting. You got to hear us use lots of acronyms. So I was sort of rolling the tape in my head, and hopefully I'll get better sharing the next meeting in person in front of our new foster youth attendees. So thank you so much. It's a huge resource for our group and help us think not only about how we engage with them when they're here, but also on the selection process. So yeah, go ahead, Julie.
Okay, so I'll start my update with that process. We had 17 youth apply for the 2 commission member positions. I put together a little committee of volunteers, mostly staff here at the Office of Court Services, as well as one juvenile judge who volunteered to help review those applications. Oh, and one of Megan's colleagues from Foster Success. And that group is actually meeting this afternoon to whittle down that group to a group of finalists who will be interviewed over the next week or 2. And then we'll be presenting John as commission chair with a list of 4 finalists. So that's where we're at right now. The youth who applied, I think have the full age range of what's allowed under law. So 18 to 29, they're all throughout there. They have experience with different systems, some DCS, some FSSA, some juvenile justice. So those are, you know, the 3 kind of large systems that are in our commission statute that we say that's how we define vulnerable youth, right? Being served by one of those. And that's who applied. So far we're meeting our intent for youth who are interested in joining this endeavor. Like I said, we'll be presenting John with a list of finalists, and hope to have those 2 appointments made in July. So they will be with us for the August meeting. And between the appointment and the August meeting, I'm going to take my cue here from Megan. I've been thinking about it anyway, and really prepare them well for, you know, orienting them to this role and the commission itself and how we run meetings and Robert's rules and all those great things, and get them ready in general, and then ready specifically for that August meeting and moving forward. So that's the update on the youth commission members. I have posted on the website a final summary of legislation. As you all know, I think I spend a lot of time during the legislative session just following all the bills that I kind of noticed that I think will have an impact on kids and families. And I have kind of organized that summary, shortened the explanations so they're readable, and categorized them by topic. And so that is available on the website. I did want to highlight just a couple of them. I mean, I didn't count the final number. There's usually around 50 or so. 1537 is the bill that adds our youth commission members. Wanted to also highlight Senate Enrolled Act 301, which creates an interim study committee for child services. And so that's, you know, similar to we have for public health or education, right, where the legislators who are on those respective House and Senate committees get together in the interim to look at issues. There hasn't been one for children and families, so now there will be. This interim, they're specifically tasked with looking at child fatality reports from both the state and the local child fatality review teams. So that'll be coming this summer. Let's see, Senate Enrolled Act 368 was a pretty significant movement in juvenile justice. So if you didn't follow that, that one does 3 things. It establishes a procedure for determining a child's competency to stand trial. I don't think we call it trial in juvenile, but the same concept. We have that for adults, whether they're competent or not to stand trial, but we've never had a process in code for juveniles, so now we will. It also creates automatic expungement of juvenile delinquency that's equivalent to a misdemeanor after a certain period of time. And it prohibits juveniles from being held in adult jails pre-trial, with some exceptions. So those were three kind of pretty big actions there in the world of juvenile justice. And then the last two I just wanted to highlight for you were 1007 and 1008, which are 1007 is public health grants to communities. So that's pretty exciting. I'm putting some resources out there in our communities to attack some public health priorities that we have as a state. And 1008 similarly created grants for student learning recovery. And that's already been mentioned, you know, some of the learning loss during the pandemic. And 1008 actually was kind of unique because that appropriated funds from the current year budget. And so those are already out, right? If I'm not mistaken, Dr. Jenner, I think that application process happened, right? The grantees were selected and that work is going on.
You're right. We it was a very, very fast turnaround, but Indiana was incredible. We had over 100 partnerships awarded in 90% of counties across our state, with over 365 unique partners, all focused on accelerated learning for kids, whether that's literacy, numeracy, or college and career readiness. And then we'll likely have a second round as we learn more, but the exciting part is the partnership with the community entity also works with the school so that shared data happens and we really understand student outcomes. So yes, that's out the door, and Indiana was amazing in applying and coming together as communities.
Awesome. So, and there are a number of other bills I'm not going to go into, but that list, again, it's available on the website. And I typically every year I present at a few different conferences for various professional groups within kind of all of our spheres. And I'll run down this list for them just to make people aware of what the legislature is doing for kids and families. Two other super quick updates. We're coming up on time. I know that you all were interested in sort of next steps with the Council for State Governments Justice Center juvenile justice review process. So we mentioned on the last meeting, there was some funding appropriated in the next fiscal year budget for that work. I'm continuing to conversations with CSG. They're already doing data sharing agreements, starting to kind of gather some data and do this deep data dive that we talked about last time. They're hoping to look at data from DCS on services for kids on probation, DOC for their programming, and then a sample of counties that all use the same system to kind of look at kind of beginning to end within those data systems. And so we're, have some of those data sharing agreements in the works. Oh, and Criminal Justice Institute for detention data. They're going to be doing those deep data dives over the next few months. They're going to also be doing some additional focus groups. And the goal will be to reconvene that juvenile justice task force with some additional folks, make some additional work groups to really kind of hone in on some policy solutions that will be consensus based ahead of the next legislative session. So it's going to be a fast timeline. Which is why they're already working on the data sharing agreements. But the idea is consensus-based, data-driven policy improvement in the juvenile justice arena. So that's really exciting. And then if you will indulge me for 30 seconds, I want to show you something that was developed, and it's maybe a little bit hard to see, but I'm going to explain it. This was developed by a group that we call like the Interagency Collaborative for Children. It's kind of an informal group, mostly folks who work for all of you. So people from the different state agencies who run different children's programs decided to put together this list of all the programs that the state offers, kind of program services, benefits for children and families in one place. And so what you're looking at is the first page. It's a 2-pager, but basically they're organized by the age at which a child might receive that service. So from prenatal all the way up into their 20s, just so that people can see, and primarily the audience for this right now is state employees themselves from the different agencies, can kind of see what other agencies have available. The second page of it is the same information, but it's organized actually by agency. So that also was just added to the Children's Commission website. It's on the tools and resources page under data, I think. Just as a tool that's out there to kind of continue to foster this collaboration among the different state agencies. We're working on thinking about family-friendly ways to communicate that information actually to families. So right now, like I said, it's more of a professional audience, but just kind of getting that information all in one place. And last, oh my gosh, it's 12 o'clock, Rajan. I'm just going to introduce you really quickly. I wanted you to meet Rajan Mega, who's our summer intern. Rajan, introduce yourself.
Hi, very quickly, because I know lunch is very important. I am Rajan. My main project this summer is working on the information sharing guide, because the goal was to have it updated every year after the legislative session, and it's not been updated in about 6 years. So that is my goal to hopefully have done before I leave for the fall. I am a second-year law student right down the street at IU McKinney. I'm also an ICLEO fellow and a trained CASA. So been telling everyone that this position right here in this office was made for me, because I get to work with not only Julie, who's a Master of Social Work, because I have a bachelor's in social work, but also the ICLEO office and then the CASA State office. So I'm just really excited to be here and excited to see the work that this commission is doing. So thank you for allowing me to go over a little bit.
Julie, could you just tell them, I mean, in 30 seconds, what the ICLEO program is? It really is to increase diversity within the legal field, and we have significant funding available. So anybody kind of looking at something interested in law, we have this underrepresented in our system, which we have a lot of underrepresented. We do have significant funding and help available. I just did it, so it's done.
Yeah, you did it. It stands for Indiana Conference for Legal Education Opportunity, I think.
We're proud of you, Reagan.
John, I think that's it.
We did have one other, I think, point of recognition.
Oh, that's right.
Is that right?
Yes, Chief Justice Rush, do you want to say something about our fantastic probation representative?
Susan Lightfoot has been with us from the beginning, representing probation officers who, I think I just was trying to look up the number, how many probationers are under the services of juvenile probation. I couldn't find it, but Susan, you've been just a wonderful representative, taking the information back to Popeye, which is the state probation officer. So thank you for your work. Your attendance has been fantastic. Your contributions have been, and we will miss you. We will be having, is it Corey George, who will be from Wayne County, head of Wayne County probation, will be the new probation officer. So thank you, Susan.
Great, it's been my pleasure. Thank you for the opportunity.
Well, I think that closes our meeting out. Next meeting is August 18th. Like I said, in person, maybe location. Nope,
State
not
library.
to be determined. State library. So I will adjourn the meeting. Thank you all.
Thank you.
Bye,
Thank you, John.
everybody.
John and Julie, great meeting. Thank you.
Thank you, Chief Justice.